as Eastern Director and Treasurer. We'll give our kind of a big spiel of who we are, how we got to be here in critical care nurse a little bit later on. But Caroline is a clinical nurse educator working with novice critical care nurses in 5 community and tertiary critical care centers. She's also on the board of directors for CACCN as Western Director. So just a quick little kind of tidbit. What is CACCN? We were asked to come speak to you guys here today about critical care nursing. So CACCN is the Canadian Association of Critical Care Nurses. We're a volunteer organization of critical care nurses. We are the voice of excellence in Canadian critical care nursing, and our shared goal across the country is really to promote quality patient and family-centered care for for all Canadians and families of Canadians experiencing life-threatening illness and injury. We do not have anything to disclose other than the fact that we are both from home. So this is my cat's bedroom when it's not my office. So he intends to be a full and active participant in every Zoom conversation I have. He is currently on my lap, and you might see him walk around. I'm sorry, there's nothing I can do. He just loves being involved. And Caroline's dog also likes to be involved. So bear with us as we navigate the presence of our pets. So I'll hand things off to Caroline for a little bit.
So what is critical care? The critical care nurse works collaboratively with the interprofessional team responsible for coordinating patient care. We use all the team members, their unique scope, their talents to meet the patient and family needs. Now, that sounds like a lot of nursing. So what's special about critical care? You know, critically ill patients must be cared for when we think about the whole of them, the integrity of them, the relationship to their family and their environment. So we plan, coordinate, and implement the care with the healthcare team to meet those needs. And we also really nurse the family. So to me, that's a really important piece of it. Critically ill, critical care nurses, we use a lot of technology, and we have to be mindful that this is a human being, but we're also using a lot of skills and machines around us. So we really use that highly technical environment, but we also need to remember about the safety of the patient, the dignity of the patient, and comfort. So all those things are related as well. Critical care nurses, we really use a lot of science. We are very research-based. To me, it's lifelong learning, and I think that's what I have enjoyed so much about this. We want to understand what it's really essential to critical care nurses. It enhances our professional competencies, advances nursing practice, and we really have to make sound judgments on what's going on with our patients. And sorry, my screen is like going black every once in a while. And so if I lose my place, it's really about our foundational knowledge, our experiences. And so that sounded quite vague, but we're going to get into more of the details. But I think that what I've always loved about what is critical care is that it is such full scope. We use a team-based approach. We have to understand the full aspects of what's going on with our patients. We see what we do, evaluate it, and then move our treatment forward from there.
So let's move on a little bit more in depth with that. So just a side note, the way that Carol and I have built this presentation really is, we'd like it to be as sort of interactive with you guys as possible. We appreciate that, you know, you guys are all graduating, if not at the end of this year, then maybe next year. And you guys are trying to figure out what specialties you want to go into. So we really want this to be an opportunity for you guys to talk to us. My background, I'm a clinician. I've always been a bedside nurse. Don't ever let anybody tell you that you're just a bedside nurse. I'm so proud of where I am today. But then we also have Carolyn, who has been, she's more in a clinical position. She's seen a variety of different positions. So we really want this opportunity to be more for you guys. I know this might seem kind of a little bit dry, But my aim is to tell you our story and kind of break those myths about critical care. There's so many memes online about what critical care is, and oh, we like patients that are intubated and sedated and don't talk to us, et cetera, et cetera, et cetera. But critical care really is so much more than that. So what are these really foundational aspects of critical care nursing? So critical care nursing historically began really when a group of nurses kind of looked at each other and said, hey, you know what, these patients here, this patient needs some closer monitoring. Let's bring them closer to the nursing station. So critical care nurses in Canada kind of really sort of created the critical care environment before critical care and intensive care unit nursing really was a thing. So, we have the tendency already in our practices to say, this patient's a little bit more unstable. Let's bring them closer to us. Let's increase the frequency of our rounds. And that really there is the foundational aspect of critical care nursing. Somebody is more unstable, so we are going to bring them into a more closely monitored area. Now, as critical care nursing evolves, not only scientifically with technology, but also in patient demographics and, patient settings. What's a critical care setting for me might be a very different thing than what critical care is in a remote area. So as you're in different practice areas, you have kind of different faces to critical care. We all kind of have this unifying aspect that we focus on a critically ill or unstable patient following either extensive injury, let's say in the case of traumas, so car accidents, pedestrian versus MVC, skydiving, plane crash, bus crash, what have you, surgical interventions, so more in-depth surgical interventions require direct transfer to intensive care. So for example, cardiac surgery, really invasive like thoracic surgeries, really intensive, long, anything that's prolonged, or that the patient is in a really weird positioning during surgery. So if they're prone for like 12 hours, you can imagine all that fluid builds up in their face, in their airways, well maintained. We're going to bring them to ICU just to kind of do a prolonged, more monitored, more close recovery phase, or any life-threatening diseases. So if any of you guys are doing your placements in hospitals and you're hearing those code blues, typically code blues, cardiac arrest, they're going to come to ICU. We can be found working in a variety of different environments and specialties. So some hospitals have their units split up. I was lucky enough in Montreal to work in ICU that we had everything together, but I currently work in an ICU where things are a little bit more separate. So you can have medical intensive care units, you can have surgical intensive care units, trauma intensive care units, coronary care units, cardiothoracic intensive care. You have burn units, pediatrics, neonatal. You can have, different trauma centers have different levels. Some ICUs, like I said, combine these areas of specialties and some of them split them. And we can be critical care nursing both in urban and rural settings. We can define them as quaternary care. So quaternary care is when you have a really, really, really specialized thing that isn't found anywhere else in the region. So for example, I'm the trauma unit. So the trauma unit for, pretty much between Kingston and Montreal. We are the trauma unit, and we receive that whole basin and from Nunavut down. So, it can be really wide like that, or really hyper specialized, or you can have an everything, or you can have what we call level 2 ICUs that are kind of like, usually they're, out of ICU. So it's like a monitoring area, like an acute monitoring area, or advanced monitoring care units, or maybe a monitored step down unit. So essentially anything that requires an advanced knowledge, and advanced patient assessment. And usually if we're looking at the definitions of it, it's anything that a patient is on a monitor. So these are your patients that really high risk of deteriorating. So we're seeing patients really on the entire spectrum. We're seeing them when they're really crashing, But we also have a strong responsibility to determine if my patient is decompensating, because there's always that risk. We have a very, very advanced exploration of disease pathology and interventions. So typically, Caroline can probably speak a little bit more to this. Typically, when you're starting your nursing career, as I think the nursing shortage has become more and more prevalent for the last, I don't know, what is it now, Caroline, like 40 years that we've been saying we're in more
As
nursing
long as I've
shortages?
been working.
Yeah. It used to be that you had to work on wards for quite some time before you could even be considered to work in the ICU. You had to have minimum X amount of hours, or you had to do a critical care course. I know some areas still really require either a critical care course or critical care certification. And now we're seeing a lot of individuals like you guys, all of you here today, and this is why we're here really, is we are seeing so many more graduates entering the critical care setting. So Carolyn will be able to speak on that a little bit later, because that's really her specialty. I'll tell you guys after a little bit about my history and how I entered critical care. But regardless of how you're doing it, whether you're starting directly from school as a fresh grad, or you have ward experience, you are usually put through the gauntlet. It's a really, really, really big learning gap. Because we don't just talk about, for example, things like blood pressure. Blood pressure to me is an extremely vague thing. We'll talk about our mean arterial pressure. We'll talk about the determinants of blood pressure. So we'll be talking about heart rate, stroke volume. We'll be talking about cardiac index, cardiac output. We'll be talking about really sort of in-depth things. And some ICUs don't have respiratory therapists. The nurse is the respiratory therapist. So then we're talking about blood gas analysis. We're talking about how to manage mechanical ventilators. We're talking about resuscitation. We're talking about all these different things. So usually there's a course that comes with it, whether it's an in-house or, for example, in Ottawa, there's the Algonquin College critical care course. I know in Quebec, McGill University, Université de Montréal, they have critical care streams built into their bachelor programs. So there's really a range of kind of education, but there will always be a huge step, I have to say. And I'm not saying this to discourage any of you guys. 100% go for that step. I fundamentally believe that everybody should be taking that step because I love critical care. But be aware that it's kind of like going back to school, because you come out of school and all the norms you've been taught and everything that you've been taught that's normal, suddenly we're like, yeah, okay, I don't really care about that because I care about these ICU specifics. So we become very, very intimately aware. You give me a disease pathology, and it's my responsibility to be able to slam out like every single sign and symptom, possible complication, so that I, as a critical care nurse, can anticipate. We're very, very strong in cellular, pulmonary, cardiovascular, neurological, gastrointestinal, genitourinary, and defense physiologies. And we also have to be very well educated on kind of psychosocial, cultural aspects, because we really do see a wide variety of patient populations. As I said earlier, I'm in Ottawa, so we actually are the care corridor from Nunavut. So we receive a lot of transfers from Nunavut. I'm in Ottawa. We have a lot of refugee claimants that are in Ottawa. We have a lot of, just different cultural aspects to care. It's my job as a nurse to be aware of what I'm saying to a patient and what that actually means for them. So it's just a lot of that awareness. And this is where Carolyn was talking about lifelong learning. Nobody expects you to know all of this going in. Nobody. It would be insane if anybody expected you to know all of this. I'm a lifelong learner. I do conferences like this. My unit does training sessions specifically on different cultures, beliefs, all of this stuff. So this is an ongoing learning. So you're never expected to know all this stuff right off the bat, but it is kind of where you get to be. We also very well versed in ethical and legal issues. We are dealing with life and death on a daily basis. And life and death is ugly sometimes. Stress is ugly. It can be manifested in difficult ways. So we kind of have to know what's going on in terms of legal rights of individuals. People are reconstituted families, chosen families, families by blood, et cetera, et cetera. So we do have an extremely high degree of responsibility, but with that comes a really high degree of pride. We are proud of, I think, of what we do. We have a very strong knowledge base. You need sound clinical reasoning and excellent communication. So if you're thinking of starting a career in critical care, first of all, there's nothing wrong with trying. There's nothing wrong with trying and saying, this is not for me. There's absolutely nothing wrong with doing that. But we need to look at ourselves and see what are our strengths and what are your strengths as you know them, not what are strengths as others know them. Because my colleagues are always like, my family and my friends are always stunned when I went into when I talk about like compassion and the compassionate side of ICU, because they're like, you're not compassionate. And I'm like, no, like I know that I am. It's just so you know yourself. So ask yourself, am I a fast learner? Do I function well under stress? How am I with communicating? Because fundamentally, at the end of the day, we are the defenders of our patient. My patient is incapacitated. They are laying there in bed, even if they're awake, physiologically, biologically, they're not of sound mind the majority of the time. They're either sedated, they're here with, states that make them confused. And we are their defenders. So I think you could probably ask any critical care nurse, there's nobody that goes into that room to touch or speak to my patient without me knowing. You don't need my consent necessarily, but you best believe there's going to be an ICU nurse that's going to say, who are you? What do you want? Can I help you? Because we really are that defender. We talk a lot about in nursing how we are the last front between, we're the last front between the mistakes, right? Possible mistakes, the physician, the pharmacist, blah, 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 blah. And we're the last catch. In critical care, we're the defender. We are the last person between my patient and the outside world. The all-important questions of nursing ratios. Yes, critical care. Most critical care for the sickest patients will be one nurse, one patient. British Columbia has just come out with some fantastic safe staffing ratios. So we have 1-to-1 nursing in the ICU. However, for kind of more stable patients, and for me, what I mean stable is, are they stable on a ventilator? Are they, is it okay for me to do their care without there being issues? Are they not? How much medication are they on? So you could have 2 patients. But what's really important to consider is that every single aspect of that patient. You know their blood work off the top of your head. You know that this person has come. You know exactly what is going on with your one patient. You are expected really to know everything there is to possibly know about your patient. And it's not a one patient. It's not really a one-to-one, is it? Because you have one patient and you have their entire family member. Our patients, for the most part, cannot communicate.
Yeah.
Contrary to popular.
Excuse me. Window proof of enrollment mo pagkaan. Thank you.
Pardon? I just didn't hear that the comment there that you had. Okay, I'll keep going. So our patients, for the most part, cannot communicate, and contrary to popular internet memes, this isn't always the easiest option, because we have to take into considerations that when my patient cannot communicate, it's kind of like an inverse relationship here. As my patient's ability to communicate decreases, their family's stress and anxiety increases. So usually if my patient cannot communicate, it's because they are sedated. Usually if we're keeping patients sedated now in 2024, if patients are being kept sedated, it's because we're doing it for their well-being. So if we don't do it, they're at high chance of dying, or they're at significant risk to themselves. So that increases their family's stress, anxiety. So then you need to be there for the family more. So not only is your patient sicker, requiring more of your attention, but their family is more and more distressed. You find yourself being the communicator, not only for the patient, but between family members. And I dedicate a lot of my time in my day talking to families. So you have to be okay with having a patient that will not necessarily be able to talk to you. And you kind of have to be okay with a patient who, even if they are talking to you, might not be saying the nicest things. Our patients are often delirious. They're often very confused, and that can manifest sometimes in mean, aggressive ways. I've had some patients over the years tell me hilarious things while they were confused, but you can get some people that are really not that fun to be around, and that can be, once again, even more distressing for family members. So I would encourage you, as you're thinking about where you want to specialize in as new clinicians, that if you're interested in critical care, reach out to your local critical care. If there's anybody here in the Ottawa area or even the Montreal area, I have a lot of connections in Montreal. If you are interested in critical care, reach out to me. I would be more than happy to talk you through it, and reach out and see if you can do shadow days in the ICU to see if it's for you. Don't rely on the things that are all online and stuff like that, because it's so much different. We don't go to ICU, to just have one patient. I cannot count the amount of days that, I don't have a break, or that, my 6 patients I used to have on the ward is less busy than, the one ICU patient that I have. Every specialty is a specialty for a reason. We all practice differently. And critical care really is one that's close to my heart. So as I've just started alluding to talking with families, I'm going to pass it over to Caroline, and she's going to talk to you guys about patient and family-centered care. If you guys have any questions or comments or whatever, feel free to drop them in the chat or to just interrupt. So Caroline, I'll just hand it over to you.
Yeah, thanks, Karine. And I think, my introduction of what is critical care, taking holistically, and Karine, you've really...
You fat motherfucker.
Anyway, I think that you've explained really how well the, how full scope it is. And there is just so many aspects. And when we talk critical care, we maybe picture just a community, not a community setting, like a really acute setting, the one patient on the life support and things like that. But there is just so many areas. And I find more and more as we are in critical care that branches off into so many other areas as well. And it is true. Karine was talking to us about being kind of that last step between all the treatments and the patient, but we're also the first step, because we're the ones that walk into the room and we do that full head-to-toe assessment. And our team really relies on what we're telling them about the patient, and we're looking for those nuanced changes and things like that. So I think as you can hear from Karine, and I feel the same way, I was agreeing with so much of what she says. It's a real passionate role to be just that person there for the family, for the patient, knowing what's going on, figuring out the things. It's like a puzzle, and yet we're working together as a team to get there, and we're really that integral piece of it. But then she also talked about it's difficult, and for many families, this is their worst situation that they've come across, and we put them into situations by asking them about treatments, and they may have no understanding of what it is. And we live in a world where we have all these treatments that we can do, but they might not understand, or their understanding of it is very minimal, or they just think that everything is an option. And so it can be really hard. And so we're not just that kind of advocate for the patient, we're the advocate for the family. We're making sure that they understand what's going on. You know, so here this event has happened and it's disrupted their entire life, what they had planned for that week. So the family now is at a situation where they're coming into the hospital, they're seeing their loved one in a strange situation. Many people are very uncomfortable in hospital situations as it is, for whatever barriers it is that gets them there, or whatever preconceived ideas or maybe experiences. And a lot of people have had bad experiences at the hospital. So that is one thing that I think I'm very passionate about it, because I just want to make sure that families feel welcomed into the room, that they feel that they can ask the questions. And my approach has always been is that I'm the intruder in this situation. They know their loved one, whoever it might be, whatever the relationship is, but they know them better than me. I might know the medical side of things and I understand the process that's happening, but they know the person. And so I always introduce myself and coming into the room and saying who I am and what my plan is. And now you tell me what it is that you need for this day. You know, people respond to critical illness of a loved one in many different ways. You can get acute anxiety. People can feel extremely helpless, grief, maybe even into depression, emotional distress. We talk a lot about post-traumatic stress disorder in patients. There's something called post-ICU syndrome, but it also happens in families because of what's going on. It's actually a big research area as well. They're looking at journaling. The ICU that I did most of my career at has put out journals with, hey, questions that I can ask, because sometimes people don't even know what to ask. So what are some questions that I can ask? And just kind of give them some conversation starters, or just writing out their feelings, just being able to express that this is really, really hard. Including families in the interventions, in the rounds. It's very hard as a medical team to have someone who doesn't understand medical things to be standing there and listening while you're doing rounds. And sometimes we feel like this is private information, but why is it? This is about the patient. Family-centered rounds doesn't happen in all sites, but it is starting to become more and more prevalent. Actually asking families to participate in some care. They can wash the patient's face, or they can help with the turn, as long as, we're being careful, obviously, that they're not going to injure themselves, things like that. But there's so many ways that we can actually have patients involved, and the more they're involved, they understand what's going on. They become part of the care. They become more, their anxiety can go down because they're starting to understand why we're doing what we're doing. Even in just suctioning a patient, it looks quite traumatic. And I always ask people, I say, have you seen it? Does it bother you? And don't stress if you need to step out, because that's another thing. I always ask families, like, don't feel like you have to be tough and watch this, because if it's too hard on you, please step out and I'll just tell you how things went. Giving patients more and more resources, as Karine mentioned as well. We see patients from multiple demographics, different areas, and just making sure that we have translation, that we have the ability to properly communicate with people, so that we're not feeling like we're over here making all the decisions and then we just tell people after, oh, this is what we did. Really, it's about person-centered care and involving the team, making sure that we understand their values too. And sometimes even bringing that. Just yesterday, I was talking with a nurse. It was her day one in the ICU, and there was a patient there, and he had been in the unit in various ICUs for over a year. And perhaps it looked like this patient was suffering, but the family had determined that this was going to be continued. And so we talked about it, and I said, I have an opinion inside my head. And I said, what about you? And she said, yeah, I have an opinion too. And I said, but we keep that to ourselves. I said, as much as that's hard to do sometimes, this is this family's life right now, and this is their world. And so we have to be really aware that patients have families. Families have beliefs about their patient. Families have beliefs that they bring into the area and that we work with those as we care for the patient. It was interesting because this particular nurse that I was talking to had a family situation herself, and she said, so I can really relate to them. And I think that's such a value, is that when we can kind of understand from whatever it is. So we do bring our other beliefs into the unit. We bring them into our day-to-day care, but we also really have to be aware of what's going on within that family unit and how we can just be there to be the support and explain as best we can through all those things. Back to you, Karine.
I'm still muted. Okay, so we're going to get on to kind of like a quick sort of summary of how each of us entered critical care and our sort of experience in critical care, because they just both kind of show different pathways and different things that you could do as a critical care nurse. And then I think that we'll open it up to kind of some discussion with you guys. Just quickly, I had a question that came up here regarding job shadowing for a student that's a term 3 nursing student in Sydney, Nova Scotia, and they're interested in critical care. So what's the best time to do job shadowing? So I'll just answer that really quickly, kind of overall. I would say the best time to do job shadowing is, typically it depends what that hospital's practices in terms of, if they have a novice nurse program. So when you're applying to a nursing job and you're looking at those nursing job postings, sometimes, a lot of the times it'll specify like if it's a novice nurse position. Because what you're applying for essentially is the training program, the critical care training program. So if they don't have a novice nurse training program, my approach has always been to find out the contact information of the people. You can usually Google this stuff, what the name of the manager is for the ICU. Send them an email. There's never anything wrong with sending them an email. The worst they can ever say is no. Fly off an email. That's how I've gotten a lot of my jobs. You just fly off an email and just say, hey, I'm a nursing student. So that, I wouldn't talk about job shadowing really until you're nearing your graduation, because they're going to be thinking of, okay, this is somebody that's interested. Is there potential possibility in hiring them? And you can tell them, I'm really interested in critical care. Can I do some shadowing? Worst that they can say is no. I would also, and this isn't a sales pitch, but I would also encourage you to get involved with CACCN. We'll talk a little bit about that later, because our events, especially our national conference that we do, is a great networking opportunity. It's a fantastic way to learn about people in your area. And when you join CACCN, if there's a chapter in your area, you're going to be connected with the people in that chapter, and a lot of them are leadership. So my recommendation for job shadowing is, if the hospital doesn't already have a shadowing program, reach out to the critical care department and see, is shadowing an opportunity? But usually it's near the end. If you're interested in critical care and you can put like a choice, let's say, for your placements, for those final consolidation placements, and you have an option to say that you want to do critical care, you can put critical care. But a lot of it kind of has to be led by you. So how did I enter critical care? Well, there's a reason I chose to answer that question right away, is because I knew really early on that I wanted to do critical care. I grew up with a father that was an ICU and trauma ER nurse in the 70s and 80s in Montreal. And so I grew up hearing about this. Obviously, I grew up hearing the glamorous stuff, but I knew I wanted to do critical care nursing. I am somebody that is extremely, extremely passionate, very professionally driven, and I love teaching and I love learning. So I knew that this was the place that I wanted to be, because everybody always told me I would have to be a lifelong learner. And because I'm a giant nerd, I would say, yes, I'm into that. So I knew early on in my nursing, I wanted to be a critical care nurse. So when I had the opportunity to have a critical care placement, they kind of asked us what our top three was, our top three placement choices. My number one was critical care. I was lucky enough, one of two, to do my critical care placement in a wonderful ICU, the Royal Victoria Hospital in Montreal. But I also knew I fell in love with it as soon as I did that placement, and I knew that's what I wanted to do. However, I also knew that I did not want to be a novice going into critical care. So once I graduated with my nursing, in Quebec, we had a diploma. So I graduated with my RN from Dawson College. I did work on the ward. So I was a ward nurse, a medical surgical ward nurse, where we did kind of hepatobiliary, general surgery, ENT. And it was a very, very acute unit. This was also a unit that I had done one of my placements on in school. And so I worked there for a year. I did my licensing exam. I started my bachelor's full-time as well, and I kept working full-time. And after a year and a half, I transferred to ICU. Now, the reason that I didn't want to go straight from, this is a personal choice for everybody, I didn't want to go straight from school to become a critical care RN because I had just learned like the norms, the normal heart rate between 60 and 100, normal blood pressure between this and this, normal rest rate between this and this. And I really wanted to solidify my knowledge of what those norms are, how they come into practice, because I didn't want my clinical perception to be skewed by how abnormal critical care is. If you're on the ward, if any of you have done practicums or externships or what have you on wards, when your patient has a systolic of 90 on a ward, that's a big thing, right? We're paging the physicians, maybe we're paging anesthesia. If the patient's on a PCA or an epidural, we're paging all of these people. And it's taking you like 2 hours. Maybe you're calling your rapid response team. It's taking you like so much time and energy to deal with a systolic of 90. And that kind of teaches you that that systolic of 90, that's a serious number. Then you enter critical care and you're like, oh, systolic of 90, we're good, or heart rate of 110 on the ward. And then you enter critical care and you're like, 110, yeah, okay, we're good. So I was worried, and I still, do believe that it's important to really have a strong understanding of why these are norms and why it's so abnormal to be outside of them. Even though these abnormal data points are typical for ICU, it doesn't mean that they're safe. It doesn't mean that everything is okay. Something is very wrong with your patient if they're sitting at a heart rate of 110, but nobody's getting really excited about it. So I wanted that strong foundation. And after a year and a half, I went to critical care. I went to the ICU. My ICU that I started working at had a phased approach. So first you did what we call the hemo training. That's the basic ICU. The basic equipment, mechanical ventilation, arterial lines, basic vasopressors, levo-fed vasopressin, et cetera, et cetera, et cetera. And then a year to 2 years later, you got your continuous hemodialysis, because that means that your patients are more acute, more unstable if they're kind of on that continuous 24-hour hemodialysis. And then about a year later, we got our cardiac surgery training, because that's another kind of degree of complexity. And then after that, you started getting your mechanical circulatory devices, so your artificial heart trainings. Then I went on to be ECMO trained. And then, which is where you're kind of a nurse that takes care of the patient and ECMO. And then I moved. I met my now husband at a CACCN annual conference in Toronto. I met him, and we were just two giant nerds that met at a nursing conference. And I moved from Montreal to Ottawa because he was an ICU nurse in Ottawa. I moved here in 2018, where I started working at the cardiac surgery ICU at the Ottawa Heart Institute. I worked there for 2 years. And then I moved over to the trauma center in October 2020. So I don't know why. Well, no, I do know why, because I struggled as a clinician to see, what was going on with the COVID pandemic. And I was working in ICU, and I'm like, well, I know how to deal with this. Why are we not doing it? But because we were a hyper specialized ICU, I was like, no. And then I went over to the trauma center, and I've been working there in the trauma ICU at the Civic Hospital in Ottawa since then. I've always been involved with CACCN. I got involved the minute I got my job offer in critical care. I became a CACCN member, and I became involved with the executive committees of the CACCN in the Montreal chapter, and I was there for several years. Then I moved on to a lot of different national committees, and now I'm on the board. I was a clinical instructor at McGill University in critical care. And I always got involved so much with different committees at work. So it's the fantastic thing about critical care is that you can do with it what you want. If you just want to come in and work, you just come in and work. But if you want to get involved in committees, best practices, like Carol and I involved with like a bunch of different advisory committees and they're making Canada-wide changes, you can do that. So just in the interest of time, I'll hand it over to Carolyn, and then we'll get to your questions real quick.
All right, so I wrote mine out because I'm not as good as just speaking as Karine is. So my nursing education was many, many, many years ago, and it was a hospital program. And so I had the opportunity to spend a month in a busy ICU in Vancouver, and just seeing that complexity of care, the multidisciplinary team, and the skills in the ICU, I was totally hooked. So I did work for a year on a surgical unit, and then I took my critical care education, and I did my clinical hours in that education in the same unit that I had, that same ICU that I had seen in my nursing school. And so, but this time I was able to participate so much more, to do the assessments, to titrate the medications, to really understand what was going on with ventilation and looking at the blood gases and saying, oh, we made these changes and this is what happened. And then reporting to this big team of physicians and physio, pharmacy, and I just loved it. I loved understanding the complexity of what was happening to my patient and seeing how we had done things. So then when I did start working, it was in a small ICU, and I did point of care nursing, and that's all I ever wanted to do. I just loved it. Not all the days were good. I will admit that. They were busy, we worked short, we had really sad situations or difficult situations. But one of the things I loved is how we really worked together as a team, and we got to know each other, because here you are doing CPR on someone, or you're celebrating someone's birthday in the break room, and we just were really a close-knit group, and it was very important to me as we went through those challenging things to have the colleagues that I really could rely on. I always wanted to learn. I took every skills day, every education day. I just wanted to know more and more, and I became more confident in my role. And I took on new skills, and I just really enjoyed that critical illness piece, doing transports to other hospitals. And I mean, if there was a code team, if there was a code, I was always the one that said, "Can I go?" So, one of the areas, though, that I felt most comfortable, and you'll get this from how I've already talked about it, was caring for patients at the end of life, and that dealing with the family, connecting with them, finding out about the family member. What was their name? What did they like to be called? Was he grandpa? Was he papa? What was he to you? And also just really finding out about them as a person. It was really impactful to me. I mean, dealing with family that's experiencing a really sad and often tragic event, it wasn't easy, but I just wanted to make sure that they remembered that they were cared for within this awful time. I don't care if they remembered who my name was or what I looked like, but just that they felt that they had been supported in this difficult journey. So that little ICU that I worked in, we moved about 3 times because the community it was in has just exploded, and it's still continuing to grow, and it's a very large 46-bed unit now. So as the unit and the staff became bigger and bigger, I actually realized that maybe point of care nursing wasn't going to always be my route. So I took on different things. I would be charge nurse, and then I took that on full time. I was what they called a clinical resource nurse. I filled in as an instructor for a critical care program, and then I became one of the educators in the unit. I was in that role in the pandemic, and I have to say that things changed so rapidly. I mean, as ICU nurses, traditionally we kind of like control. Perhaps that's a bit of a stereotype, but there is some truth to it. And we didn't have control. We were receiving information, you're going to do it this way. Then the next day, oh no, you're going to do it this way. And it was really challenging. We felt all very stressed and overwhelmed, not just the volume of patients we were getting, but the way we were to care for them was changing. And I think everywhere in nursing saw that. But I think that ICU was probably highlighted in that. However, we did know how to change and adapt, and we persevered. About 2 years into the pandemic, I was offered a new role as a teacher in a new education program, and I did leave. And it wasn't because of the pandemic, but it was because I do really love teaching. It was hard for me to leave my site that I'd worked at for 25 years and the friendships and the relationships I'd been with there, but I did. And I have to say, it's probably been one of the best roles that I've done. I did teach, and I integrated nurses into critical care. And then that actually led into my most current role, which is like a mentorship role. So I cover 5 different ICUs within the health authority that I work at. And I support nurses prior to coming into critical care, as we are seeing new pathways where employed student nurses and preceptorships and new grads are coming in, as well as I support nurses after they've taken a critical care program. Because as Karine has said, there's a lot of nuances, and you just I shouldn't say just, after taking the education, there's still so much more that needs to be integrated and learned. And that's becoming more and more challenging in the ICUs as we have more senior staff leaving, and we have more critically ill patients than we have nurses to care for them. So it is a much different integration than when I started many, many years ago. And so I find it a great joy to go in and support people, whether it's just, hey, do you need me to wash your patient? Or do you want to talk about what's going on with your patient? Or do you just need to go have a coffee break and I'll cover your patient? Or we get right into what's your career planning and how are you going to get there and what's your next course? Or just yesterday on someone in her very first day who actually just wanted to talk about kind of the moral dilemma she was having, and it came from a very personal place for her. So that is kind of what I do now, and I'm enjoying it a lot. I have to say, it's kind of fun to be able to just hear the stories, and I do love all things critical care. Perhaps I'm a little more positive than I should be some days, because I just think that I have a great passion for the role and how it was a big impact in my life and my career. And it's kind of a nice way to, well, I'm closing in on my retirement, so it's a nice way for me to be now. I think we're probably done our formal part. Oh, we do want to just talk about,
our little spiel on CACCN.
Yeah.
I just figured I'd take it down, that way we can see each other like when we're talking. There you go. Did you want to talk about CACCN, Carolyn? Or I mean, it's just a really quick. So, yeah, you can go ahead.
Yeah, so we do CACCN. It's our national organization. Why would you want to belong to CACCN? There's lots of different reasons. We have a journal called the Canadian Journal of Critical Care Nursing. We recently had standards that we just sent out. So this is kind of our national standard for what all ICUs within Canada should be following. We have position statements and practice guidelines. We have awards, grants, and bursaries, lots of educational opportunities. There is the Canadian Nurses Association has certification, and CACCN provides the resources for that, multiple webinars and journal clubs throughout the year. As Karine has said, we do a national conference every year, which is so inspiring to meet fellow nurses from across the country and collaborate and learn together. There's a few other things. We have some joint memberships. For me, I just find that hearing about nursing right across the country, I didn't know before I belonged to CACCN what was going on around our country, and it's so different. And yet, hearing people's passion is just really inspiring to me. CACCN is also part of a world federation, and I recently was able to be a part of that meeting just to listen in. And it's exciting to see how Canada can provide resources throughout the world to lower and middle income countries, because we do have the ability to share our resources, our research, and things that are going on. So yeah, we encourage you. There is a complimentary student registration. Hopefully you can use that QR to get the link. And now I think we can open it up. We have 5 minutes.
Yeah.
Thank you for those that have put in questions in the chat, but feel free to unmute yourself as well if you have any
Yeah.
questions.
I'm mindful of the fact that you guys are going into lunch after. So I mean, if I'm happy to stick around and answer more questions and stuff like that. I could have gone forever into what ICU nursing is and stuff like that, but I tried to kind of keep it light. But yes, that complimentary student registration, so that's free. If you're doing your bachelor's, you could become a member of CCCN for free. So you get access to like a ton of our webinars and stuff like that. So, and that networking, which is really, really, really phenomenal. I'll just go over quickly some of the questions that popped up in the chat. So somebody asked, what kind of unit you should be working on if you're thinking about doing critical care, but you do want to do some ward nursing. Really, any medical surgical is fantastic, because what that does is, on that floor, you'll have 6 patients, right? And you'll know what's going on with your 6 patients. And you'll have the degree of understanding of your patient that you're expected to have on that unit. And all their medications and this, and they need to get up and they need to ambulate and their meds due at this time, and this is their diet and blah, blah, blah. And you're going to get used to doing this for 6 different patients. Then when you move to critical care, what'll happen is you will take literally all of those 6 patients and you will stick it into one. All because your ICU patient will have a ton, like really, really complex needs. And so if you learn to kind of organize yourself for 6 different patients, suddenly when you need to pull them all into one, it's not really as daunting. So any medical surgical unit really, that provides a really strong foundational kind of base for your critical care nursing. You can join CACCN without being a critical care nurse. It's open to absolutely everybody. That was one of the questions. Courses and mechanical circulatory support. And somebody wants to know where they can find more information on things like that. So things like ECMO nursing courses. So this is a course given by ELSO, which is kind of the International ECMO Extracorporeal Life Support Organization. These are really courses that you kind of need when you're like a really strong ICU nurse, like kind of like 5 to 7 years. Any other courses will usually be given in-house. So if you're doing advanced training for your dialysis or stuff like that. But CACCN, we do offer a ton of webinars. There's different things on Continuous and stuff like that. And Brenda Morgan, who's really a pioneer Canadian critical care, gives a really good ICU review course. They're not cheap, they're about $1,000. In-house critical care courses depend. Your training really depends. I think college is usually 1 to 2 years, and in-house ranges usually from like 1 to 6 months. RPN role in critical care. So this varies. So the question just popped up, speaking to RPN role in critical care. Personally, I've never worked with RPNs in critical care. None of the critical care settings that I have ever worked or interacted with allow RPNs. Provincial scopes will vary. One of the requirements for an RPN is that their patient be stable. No patient in critical care can ever be deemed stable, really. And things can change so quickly in critical care. Just because your patient is stable doesn't mean the patient is next to you is unstable. And Carolyn alluded to it, that it's so important that we are working as a team. So just because you might have an easy patient or a quiet patient for your shift, I guarantee you, that those around you do not. And we really are expected to help our colleagues. So because of that degree of unpredictability, RPNs, and Caroline, maybe correct me if I'm wrong, I can't speak obviously for all ICUs across Canada. It is not typical for RPNs to work in critical care.
I have not seen that, no.
I'm currently in my first semester of my 2-year nursing program of U of T. What do you wish you knew about working in acute care before you started, / what is one thing you wish you could have done differently? Ooh.
I know that. I was just thinking about that.
I wish that I knew that I didn't need to be as strong as I thought I did in terms of emotionally. We haven't talked about the emotional aspect.
It is, that's good. Yeah.
Yeah, that's a really good question. So I thought I was okay with death. I'd been an ICU nurse for 8 years or so, 7 years, when I moved from Montreal to Ottawa. In Montreal, I was a medical surgical ICU, cardiac surgery focus. I thought I was okay with death. And then I started working in this trauma center. And the type of death that I started seeing was very different. And I thought I had to be strong, right? I thought I had to be, I'm a critical care nurse, right? Death shouldn't faze me. This shouldn't bother me. And I think it's in that ignoring the fact that I'm also human has been one of the detrimental things, I think, in my career, because we learn to kind of, I guess, suppress our needs. You guys generationally, I think that the newer generation of nursing students is way better at this than my generation is. I'm 34. And I think that we're already better than the previous generation was with this. But I wish that I knew to listen to myself, and that I knew to allow myself to feel the things I'm feeling. It's okay, as Caroline alluded to earlier, these aren't things that you're going to say to your patient's family, but it's okay to feel those things, and it does not make you weaker. I wish that I would have known how hard it would be emotionally on me working in critical care, because I've worked 2 shifts recently, and both shifts my patients died on those shifts. So it is a lot of death. And it's not pretty death. It's very rare that there's peaceful deaths in the ICU. The death is usually, after a 30, 40-minute long cardiac arrest, code blue, CPR, catastrophe, or it's really after we've given every last ditch effort, all hands on deck. Maybe that nurse had maybe that patient had 3 nurses that day, all on them. So our deaths are very rarely peaceful. So that's what I wish I would have known. And what I would have done differently from that, well, I think that I would have started going to therapy earlier for PTSD. Yeah. What about you, Carolyn?
Yeah, I think probably just backing that up, and I'm not going to share how old I am. I just have to say that probably not being so hard on myself to make sure that
yes.
Like I think that's probably, like, my expectations were very high, and perhaps that is what drew me to critical care, because we do feel a lot of control there and stuff like that. And so I think when I first started, so I am of a generation where we kind of had like, there was the old nurses that would kind of tell you off, and you were a little bit scared of them. And so we did kind of have that pressure to always be absolutely perfect in every situation. And I can still remember comments people made to me like 30 years ago. So, not being so hard on myself. And I think, Karine, I'm just going to say about the death and dying piece, it depends on the ICU that you work in, because we do have where we would do what we call end of life care, and it can be a peaceful situation. However, they didn't get into ICU in a peaceful way. Nobody comes in that calm controlled way to come to the ICU to die. It has always
Yes.
been a journey, and then yeah. So, however, and we're adding this more and more to our critical care education, is that being okay. Not only are we providing care to the family and the patient at end of life, but then how are you going home and dealing with that and caring for yourself? And I think the shift work, the expectations of while you are at work, plus that emotional things that you go through while there, what are you doing outside of that to care for yourself so that you aren't really hard on yourself, mulling those things over? Because I probably did a lot of that through the years, and it hasn't always been good for me. So that's what I would do differently.
We do, yeah, we are working a lot towards kind of palliation. We do palliate in ICU. Yeah, I just want to clear that misconception. We do palliate. It's just it's usually, after, usually a prolonged illness. And then we do withdraw care. And when it does happen, we do, I think that everybody around is very mindful and very supportive of families as well. We have a 3 wishes, 3 wishes initiative that looks at making death better in the ICU. So if you're trying to figure out what specialties for you and critical care rings to you, and oftentimes there's a lot of talk between kind of ER and ICU. The way that I describe ICU as ER is an uncontrolled chaos, and ICU is a controlled chaos. So if you're the type of person that you're like kind of like go, 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 and you don't mind chaos, like, if you're, ER, the point of ER, the entire point of ER is patch them and ship them, right? Where they're patching and shipping them back home, patching and shipping them to ER, patching and shipping to the ward, patching and shipping to the ICU. So if you're a go, 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 go type of person, ER, probably awesome. They also have an Emergency Nurses Association. If you're ICU and you like a bit of a more controlled chaos, we're the place for you. You can do so much with ICU. I was wondering, what is something you did in the early days of your schooling that you believe set you up for success in your career? Oh, I was a giant nerd. I'm not gonna lie.
Me too. I took note. I mean, I had a little notebook, but
Yeah.
I know now most people have different
Curiosity.
things. Yeah, curiosity. Yeah.
And that's the one thing when I'm precepting my students, when I was a teacher, when I'm a preceptor, is, that game that kids play, and they're like, Auntie Karine, why is this rock, outside? Well, because of this. Why? Why? As adults, like, I kind of always kept that. I'm a bit chaotic in my brain. So I always ask why. No matter the situation, I always ask why. My patient's heart rate is 110. Why? What are the possible causes? Why? And kind of just that thirst for knowledge, and following that thirst for knowledge. And you know what? Doing something that you love. Doing something that you love. So just really, I absorbed everything like a sponge. I think in our day and age, it's really we have to be mindful of where we absorb our content from. So making sure that they're really good academic.
Yeah, I
What
think
about
the
you,
same.
Caroline?
If I had a patient that had a diagnosis and maybe it had nothing to do with what was going on in the situation, but I'd always wanted to look it up. I don't know how many rabbit holes I've gone down of looking
Yeah.
up things, and I just saved resources because I like lifelong learning and taking courses. If they're offering something for free, I would take it. And I feel that that's probably the thing that I did the most because I just always wanted to know more and more. Yeah.
And
We're running out of time, but there is one more question there. It says, have you ever
Yeah.
thought of travel ICU nursing? And for me personally, no. And the reason is I love a team and I love getting to know people within that
Yeah.
and that coworker culture.
Yeah.
So for myself, I'm also very embedded in my home with my family around me, and that's where I place my value. But do I I'm really inspired by travel ICU nurses, and I love talking to them and hearing about that sort of areas and how they I think it takes a kind of person that's okay and very adaptable and able to fit into a culture quickly and pick up on those things, because every ICU has a way of doing things. Patients are patients everywhere, but it's all the surrounding environment that is very different within our country. So to me, that's one thing. If you are interested in travel nursing, just thinking about who you are as a person and if you're able to adapt to that. But yeah.
Yeah, I think the same. So with travel nursing, I think that the thing with travel nursing is that, you know, I got to be kind of the leader that I was in my unit, in Montreal particularly, because I had been there, because I had established myself. I had my professional reputation, my colleagues. I gained a degree of respect with my colleagues. I was, charge nurse. I was, I did all of this stuff that really allowed me to progress professionally, and let's be honest, looks really impressive on a CV, because I stayed in one place. What gets me through my colleagues. You get to know your colleagues. You get to know this colleague is really good at that. So if I'm struggling to put in this IV, I'm struggling to put in this NG, I'm not sure about this, I know which colleagues to go to. You build that teamwork because you cannot nurse in a silo. So travel nursing has never appealed to me in that sense, because one of the things that was important to me really was to be the best professional that I could be. And for me, that definition, and once again, this definition varies for everybody. For me, that definition was to excel and to become a leader and, a mentor on my unit. And you can't do that if you're going from place to place. My old person recommendation for all of you aspiring travel nurses, because I know that this is a huge, huge thing right now, is just be mindful that this is not going to last. This is costing our governments millions and millions and millions of dollars. I'm pretty sure this is going to come to an end real soon. I know that Quebec has outlawed private agency nursing in Quebec. So provinces are starting to look at this, and just be mindful that if you're entering a travel nursing career, just to think about your future as well, how you're going to plan for your retirement and stuff like that. Because I know a lot of other generations talk about pensions, et cetera, et cetera, et cetera, putting aside for your retirement.
Here we are. We're well into your lunch
I
break.
think
I
just one last
just
one is,
answering about the going as a new grad. It really it depends.
yes,
It's very personal, depending on where
yeah,
you are at. I would talk to people and each site. I'm sorry, I'm talking about the going in as a
yeah,
new grad rather than
mhm,
med-surg experience. Yeah. And so we
yeah,
are seeing it more and more.
mhm,
I've talked to nurses right across the country, and each site is different, each area is different, expectations are different. You can find yourself feeling rather overwhelmed early,
yeah,
depending on the programs that are available within that hospital or that unit.
yeah,
However, if you know, and this, I very recently talked with a nurse locally here, and she did her new grads in critical care because she spent a preceptorship medical floor and thought she would never finish her BSN because it was just not what she wanted to do, and really struggled. And just through some conversations, they got her into ICU, and she's just
mhm,
thriving. So I think Karine had talked about it way back, but just like evaluating where you're sitting, how you're feeling, and don't worry about saying yes and then saying, oh no, this isn't for me. There are lots of there's lots of time in your career. There's
Mhm.
lots of opportunities to take a step back from something and go back into it later.
And
And just doing some evaluation of where it is that you're at. But don't be sitting in a job that you absolutely are struggling with because you think you have to do 2 years
Mhm.
here to get into ICU, because that's not true. So
I think
you,
that ICU historically was seen as kind of the place to be, right? You had nurses that sort of worked on wards, and their goal was to go into critical care. And so you kind of build up that experience with your aim to go to critical care. And people would go to critical care and stay in critical care for the rest of their careers. That trend is kind of less and less. People aren't really staying on one unit um, for their entire careers. It's becoming more and more frequent that people kind of hop from one unit to another. What I will say is that once you're in critical care, and I'm not going to lie, you get used to having two, at most three patients. It's then very difficult to turn around and go back to six patients. I'm not going to lie to you. I would never be able to go back and do any ward nursing. The thought of having to float to a ward terrifies me. I'm a critical care nurse through and through. I would never be able to do just a basic patient assessment because I've been trained my entire career to do in depth and know every single aspect of my patient. So look at who you are as a person, professionally, personally, see what your aims are, your goals are. All I can say is if you're considering critical care as an easy option, just having one patient, every single nurse that comes through our doors that has that attitude, they do not make it. They do not make it because your colleagues kind of sense that from you, and then it's really hard to integrate into a team. But it's so much more than, oh, it's really easy, we just have one patient. Because the things you're expected to know about, there's a reason that there's those memes online too about ICU nursing, like giving, like, I don't know if you guys have ever gotten a report from an ICU nurse when you're transferring to the floor, but we're really freaking detailed. So just, yeah, look at who you are, the kind of person you are, and ask questions, reach out to people around you, reach out, going back to that student of what you could do in your schooling that has been instrumental. Make it known that this is what you want to do. Talk to your professors, talk to your teachers, your clinical instructors, your what have you. Make it known, I want to be a critical care nurse, this is what I want to do. Ask them if they have guidance and support. Make it known, because then they're going to think of you there's something that comes up for critical care. Yes, it's normal to not know which field of practice you want to go into. My advice for you, try something. If you hate it, move on. There's
lots of opportunity.
There's so much opportunity.
And you still have lots of areas to
Yes.
see. Like I thought I'd love maternity. I didn't like it at all.
Yeah. Take any shadowing opportunities. Usually hospitals will have like hiring fairs or shadowing opportunities. It's okay not to know. Right now, all you're focusing on is learning to be a nurse. It's so rare that people know exactly what kind of nurse they want to be right off the get-go. I knew because it was imprinted on me growing up. Just don't stop trying until you find your fit, because there's hundreds of opportunities you could be a nurse in a school. You can be a nurse in a clinic, you can be a nurse for research, there's so many different options. Coming to conferences like this is my first recommendation really for you. Just keep getting your feet wet, really. Any other final questions before? Don't hesitate ever to reach out to CACCN. I would 100% recommend you guys join CACCN if you are interested in critical care, but just so that you can make those networking links. Our next webinar, I'm the speaker at the next webinar on December 5th. It's a members only webinar. We're talking about NMDA receptor encephalitis, We're talking about serotonin syndrome, and we're talking about Powassan virus, which is the messed up tick stuff. Oh, thank you. We are passionate about critical care. We're giant nerds. But yeah, thank you guys so much for being here. I'm mindful that, the other person that was presenting at this time is a fantastic speaker as well, but so excited to have you guys here, and good luck on your journey as students. Thank you for choosing nursing as a profession. It's a hard one, but it's full of really passionate people, and welcome to the family, really. Yeah.
That's true. Thank you so much. Reach out if you have any more questions.
Yeah.
Thank you so much, Karine and Caroline, for taking over that. Like, we really, really appreciate you sharing your knowledge with us. I think all the participants also feel like that way. Thank you so much for coming in.
Okay.
I have a tiny bit of thanks to say, like, Caroline and Karine generously donated the monetary gift card that we offered to them to one of the students. So I have a wheel of names prepared here with everyone who joined in this part of the conference. So I'm just gonna go ahead and share my screen, and let's see who is the lucky winner here. I tried my best to keep up with all the names, like who were for the people who were coming in. So if by chance I've missed someone's name,
Oh,
let me know, okay? Okay, let's see. So is Marie here? I think I saw that name here.
Maybe Sheila. Yeah, she left.
I guess better luck next time then. So we'll try again and see if there's anyone who's present at the moment.
Oh, y'all can't win. Who's COT?
Is this
You
person
guys.
here, Record or CNSA? Is this person here? Use the chat if you hear me or if you are here.
Let's do it again.
Okay, let's do it again. MC, are you here?
Yes, I am actually.
Oh, perfect. Congratulations. So we have a winner. Perfect. So all you gotta do is send me a text with your email address, and I'll send you the gift card. And thank you so much once again, Caroline and Karine, for generously donating that to CAMC. Thank you so much.
Thank you guys so much for being here.
Thanks, everyone.
Thank you so much for taking time out of your busy schedules to do this informative session. Thank you.
You're welcome. Okay, bye.
Bye. And for the rest of the students, it is currently break time. Our next session is going to be starting in about 25 minutes. So it is currently lunch break, so you guys can go grab a bite, and then we'll be starting our next session. It'll be in our main breakout room, or in our main room, in about 25 minutes. So yeah.
How do we get back to the main room?
I'll just close all the breakout rooms, so then you'll be in the main room.